Imagine having to see 30 patients in 1 hour. Yes, 30 patients in 1 hour. You have 2 minutes for each patient to develop a relationship with them, talk about what is wrong, diagnose them, and prescribe the necessary treatment. Impossible, right? According to the Escape Fire documentary, Dr. Andrew Weil, a professor of medicine and public health, explains how the time allotted for patients has shrunk to a point where you only have 7 minutes with each patient, which could eventually go down to 2 minutes. The reason for this is the fact that the government pays healthcare facilities based on how many patients they see instead of basing things on outcome and how good of a job they do for their patient. Whether a primary care doctor needs 5 minutes or an hour with their patient, the government only sees how many patients were treated and how many services were provided for the patient during the allotted time. Dr. Erin Martin, a primary care physician in Oregon, wants to do good and helps her patients, but without enough time given to speak with each patient, there is no way she can accurately treat her patients so that they do not come back for the same reason. Fee-for-service has and will continue to worsen the quality of care unless appropriate action is taken. After much thought and research on this subject, I have come to the decision that a good solution to the poor quality of care caused by fee-for-service programs is to replace it with a pay-for-performance program. A fee-for-service program is a reimbursement program that pays physicians based on how many patients are seen and how many services they provide, while according to Courtney Baird, the pay-for-performance model offers financial incentives to providers such as physicians, hospitals, medical groups, etc., to improve quality and efficiency. So they get paid what they would normally get with fee-for-service, plus the bonus if they get an overall better outcome with their patients. There are many approaches that you can go about the pay-for-performance program. The approaches include alternative incentive structure, benchmark structure, and qualities measure structure. For the alternative incentive structure, it focuses on the rewards and penalty-based programs. The rewards-based programs are when you are guaranteed bonus payments for clinicians meeting specific performance goals, while penalty-based programs are the same thing, but instead of receiving bonus payment when you reach the goal, they do not give you the reimbursement if you do not reach the goal. The second approach for the pay-for-performance could be the benchmark structure, which could be the absolute or relative performance method. The absolute performance method is when you receive an incentive when you pass a goal that has been set by the government, while relative performance is when you pass a performance from your own company's past results. Lastly, it would be the quality measure structure, which can be managed by the process-based method or structure-based method. These options allow each company to customize the pay-for-performance program to their needs that still helps improve quality of care. When changing the way you reimburse your providers, there's a lot to think about. In regard to the pay-for-performance program, there are many topics that you need to think about before implementing these incentives for a healthcare facility. The program should pay off if you put enough thought and effort into your plan. According to the U.S. Merit Systems Protection Board, certain questions that they believe needs to be asked are things like, what goals do you want to set once the pay-for-performance program begins? Which employees should be rewarded? How should the employees be rewarded? The U.S. Merit Systems Protection Board said that if done correctly, implementing a performance-based pay system can also help agencies move in the direction of success. There are many studies and programs that have been shown to be successful or improve significantly. In the first year of Medicare's program in 2005, they awarded nearly $9 million to all hospitals that participated in the pay-for-performance. They also mentioned how the quality of care significantly improved in all 5 clinical areas that they were studying, which include myocardial infarction, heart failure, pneumonia, coronary artery bypass graft, and knee and hip replacement. As stated in the pay-for-performance works, this change is expected to provide long-term savings because of their demonstrated relationship to improve patient health, fewer complications, and few hospital readmissions. This suggests that although you cannot see the difference in cost savings and only quality of care as of right now, with time you will start seeing how much money you are saving in the long run. There are several other programs that the Center for Medicare and Medicaid Services has started up to show the success of what the pay-for-performance program could be. These programs continue to run, the more these programs continue to run, you will be able to see the positive effects of pay-for-performance programs. After discussing a change to the pay-for-performance program, I think it is crucial that we start implementing it throughout the United States sooner than later. The pay-for-performance has a lot of flexibility to plan in it so that it is unique to each healthcare facility. It has been shown to bring back positive results on the quality of care. Do we really want to wait until it gets to the point where physicians have to see 30 patients every hour? No, we need to make the change now.